Okay guys, Timmy coming at you. Today what I want to explain to you is the functions of antidiuretic hormone. And when you speak of antidiuretic hormone, when you don't have enough or you have very little, so no ADH or very little ADH, that leads to diabetes insipidus. Now, if you have too much ADH, right? So no ADH, diabetes insipidus. Too much leads to syndrome of inappropriate ADH secretion. All right. So again, no one can argue with this. To understand a particular disease, in this case, hormonal problems, if you know what the hormone does, then you will know what will happen if you don't have enough or you have too much. So one of the basic functions of ADH is to reabsorb water in the nephron back into the blood. And again, anytime you increase your blood volume, you're going to increase your blood pressure. So ADH increases your blood volume and therefore your blood pressure. The other thing it does is it causes arteries throughout your body to constrict. So the lumen, or the hole the blood flows through, gets smaller. So if the arteries get smaller, they vasoconstrict because of the effects of vasopressin or ADH, then the left ventricle has to try to generate more pressure to get that same amount of blood through. So the basic function of ADH ultimately is to increase your blood pressure. Now, before I talk about that, I got to talk about the concept of osmolarity. And I made up some numbers here, right? So osmolarity, again, is a measurement, right? So it measures the ratio of stuff to water in the blood and stuff to water in the cell. So when you talk about increasing that measurement or increasing osmolarity, if you look at these numbers, and again, I'm making them up, it's stuff over water. So if I have 2,800 stuffs and 10 waters, my osmolarity is 280. Now, what's one way you can increase the osmolarity? Well, you can increase the stuff and keep the water the same. So in this case, the osmolarity goes up to 300. The other way is to keep the stuff the same and decrease the water. So in this case, you kept the stuff the same, but you decreased the water, so osmolarity will go up. Now, one of the things, well, a couple of things that you have to know is remember that arteries and veins are just to transport blood to and from the cell and then to and from the heart, right? So the only place that nutrients and gases are really exchanged is at the level of the capillary in the cell. And we've talked about this. However, one of the things you have to remember, and you learn this in AMP, is that the arterial end of the capillary and then the venous end of the capillary, right? And as that blood, arterial blood that's high in oxygen, comes to the arterial end of the capillary, it's under pressure. And it's a relatively small pressure, right? Capillaries are only one cell membrane thick. They can't handle a lot of pressure. So what happens is this pressure of the plasma of the blood on the capillary wall, what it does is it tends to force fluid out of the capillary and into the interstitial space. Now, the reason you don't have big bags of fluid in your legs all the time is because your body has a lymphatic system. So lymph vessels, what they will do is any water that accumulates in this space will be grabbed and transported back to the right side of the heart by lymph vessels. So lymph vessels are kind of like the sewer system of your body. Now, there's water in the interstitial space, right? And that pressure of water in the interstitial space, what that does is that tends to force fluid back into the capillary. So you have these two fluid pressures pushing on the capillary wall, right? So kind of like a tug of war. Now, normally, capillary fluid pressure tends to be greater than what's referred to as interstitial fluid pressure. So if you look, there is a net movement, right? Because this pressure, capillary fluid pressure, the fluid that's in the capillary, pushing it out into the interstitial space, tends to be greater, right, than the fluid in the interstitial space getting pushed back in. So there is a movement of water out of the capillary and into the interstitial space. Now, why don't you have big bags of fluid? Because the lymphatic system will take that excess fluid and then return it back to the right side of the heart. So one of the things that determines capillary fluid pressure is blood volume. And blood volume also is a big determinant of blood pressure. So if you decrease your blood volume, you're going to decrease your blood pressure. And if you decrease your blood pressure, that is going to be transmitted down to the level of the capillary, and then your capillary fluid pressure is going to drop. So if we look at that, and we look at the capillary, and remember the hypothalamus measures, keeps an eye on osmolarity. So embedded in its cell membrane, you got these little osmoreceptors, and it detects changes in osmolarity. And these osmoreceptors are stimulated in the H cell by an increase in osmolarity, right? We also recall that the H cell and the pituitary gland are intimately linked, right? H cell neural, pituitary gland glandular. So let's look at this. And several things can cause the release of ADH, but it's primarily an increase in osmolarity in the hypothalamus. So let's say that you're bleeding your own blood. So if you're bleeding your own blood, then that's going to cause a drop in blood volume. And what did I tell you? If there's a drop in blood volume, there's going to be a drop in blood pressure. And if there's going to be a drop in blood pressure, then there's going to be a drop in capillary fluid pressure, right? So what's going to happen at some point is that the fluid that's in the interstitial space, that pressure is going to become greater than capillary fluid pressure. Why? Because you're losing blood volume, you're bleeding your own blood. So interstitial fluid pressure at some point is going to become greater, and it's going to cause the movement of water from the interstitial space back into the capillary to try to maintain that blood volume. Well, what did you do? You kept the stuff the same, but you decreased the water. Why? Because it's getting pushed back into the capillary. And if you keep the stuff the same and decrease the water, you increase osmolarity. And any time there is an increase in osmolarity, that's going to stimulate osmoreceptors in the H cell. And then the H cell is going to begin the production of ADH. And any hormone that's produced in the hypothalamus is released from the posterior pituitary. So there's an increase in osmolarity. Hypothalamus produces ADH, travels through that little portal circulation between the hypothalamus and the posterior pituitary, and the posterior pituitary dumps ADH into the blood. Now, you should have learned this in general, or if you've had advanced, then you definitely learned it. That embedded, here's the collecting duct. So in the nephron, the plasma of the blood gets filtered, then it travels through the yellow brick road. And then as it travels through the yellow brick road, stuff gets reabsorbed back into the blood. Now, in the absence of hormones that affect the nephron will always make a dilute urine, always. But there are two hormones that powerfully affect blood volume. One is aldosterone, and it primarily affects the distal convoluted tubules and causes sodium to be reabsorbed and then therefore water to get reabsorbed back into the blood. And then the other one is ADH. Now, normally the collecting duct is impermeable to water, but in the presence of ADH, what ADH does, it actually inserts these little water channels into the cells that make up the collecting ducts. So in the presence of ADH, water that would normally get peed into the toilet, now because of these aquaporins or these water channels, that water gets reabsorbed back into the blood. So your blood volume goes up and your urine output drops. So when people are bleeding, then their urine output should drop due to the effects of ADH. And ADH just affects free water, so it doesn't have any direct effect on the reabsorption of electrolytes. So it just deals with water. And if you look at the name, right, diuretic, as you probably know, makes you pee. Anti-diuretic means makes you not pee. So that's one of the big effects of ADH. Now, if you look at the condition called diabetes insipidus, there's basically two types. There's central diabetes insipidus, and that's primarily a problem with the posterior pituitary. So little or no ADH is released. And then there's nephrogenic. Genic means to originate, right? So nephrogenic means that the pituitary may in fact be releasing ADH, but it's not affecting the kidney the way it should. So the kidney's not responding to that ADH. And those are the two big ones. And normally it's a result of head trauma. You get a bump on the gourd. You can get aspirin overdoses, one, and lithium. So people with bipolar are treated with lithium. That can produce that. And genetics. There is a familial genetic condition where the pituitary gland simply does not produce ADH. So let's look at this. If you look at the signs and symptoms, right, it's pretty simple. Now watch. Why would you get intense thirst? Well, let's look at that. Remember, the hypothalamus controls hunger, temperature, and thirst, right? So anytime there's an increase in osmolarity within the H-thal, especially like if you're bleeding or you're dehydrated, that's going to trigger thirst. So these people are really intensely thirsty because their blood volume is so low because they don't have any ADH. Then they're going to be peeing a lot. Very, very dilute urine. Remember, ADH concentrates the urine by reabsorbing the water. So if you don't have ADH, the pituitary ain't producing it, or the kidney's not responding to it, then you're going to have a very, very dilute urine. Then you're going to develop hypernatremia. Now, this is a concentrated hypernatremia, right? Because electrolytes are measured in milliosmoles per, milliequivalents per liter. So if you reduce the water and keep the sodium the same, then the concentration of sodium is going to go up. then they're going to have low blood pressure, obviously, because they're peeing out all that fluid. They're going to have very dry skin, right? Because all of that water is getting sucked and peed into the toilet, and they're going to be constipated, right? So you're trying to reabsorb water from the GI tract, and if you don't have a lot of water in your poop, then it becomes hard and you become constipated. So how do you diagnose it? Well, history, right? So this person's peeing all the time, they're drinking all the time. So the first thing you have to do is rule out some of their potential causes. One of the potential causes is diabetes mellitus, right? And if the blood sugar is okay, because ADH doesn't affect the blood sugar, then you should be able to rule that out. Now, the gold standard is the water deprivation test. And basically what happens is the patient goes without water for about 4 to 18 hours. And then what you do is you measure the urine osmolarity. And if the kidney doesn't concentrate the urine, then you know that it's something to do with ADH, right? So if you're not drinking any water, your blood volume should go down, right? The osmolarity in the HDL should go up, and that should trigger the release of ADH from the posterior pituitary. Now, to determine whether it is central or nephrogenic, you can also measure ADH as well. So if you measure ADH and there is no ADH during that water deprivation, then it is central. It's a pituitary problem. Now, if you give them the water deprivation test, measure the ADH, and the ADH is elevated, but they still can't reabsorb water back into the blood and their urine is dilute, then you know that it is nephrogenic. So, what do? Well, if it's central, then you give them basically a synthetic ADH, which is desmopressin. If it's nephrogenic, then here are some medicines that have been shown to work. Hydrochlorothiazide is actually a diuretic. It's a potassium-sparing diuretic. And basically what it does is it prevents the reabsorption of sodium via the kidney, right? So if you don't reabsorb sodium back into the blood, then water is going to stay with that sodium and cause you to pee more. Now, if there's a lot of sodium in your urine, then that's going to cause the release of aldosterone. And that's going to activate the renin-angiotensin-aldosterone mechanism. And aldosterone causes the reabsorption of sodium and therefore water. And then amiloride, that prevents the reabsorption of sodium via the kidney. And again, if you don't reabsorb the sodium, then that's going to activate the renin-angiotensin-aldosterone mechanism. And again, aldosterone increases your blood volume by reabsorbing sodium and water. In Indocin, they're not really sure how this works, to be perfectly honest, but it does work. So those are the treatments for central and nephrogenic diabetes insipidus. All right, so now let's look at the opposite case. And the opposite case is syndrome of inappropriate ADH, and that's where you have an excessive amount of ADH released. And again, ADH only deals with water, right? So in diabetes insipidus, you don't have ADH, so you're peeing out all that water, so that's going to concentrate your sodium. In SIADH, you have too much ADH, and as a result, you're going to be reabsorbing more free water, and you're going to dilute the plasma of the blood. So you'll have what's referred to as a dilutional. I don't think I spelled that right, did I? Dilution. No, I think that's good. Dilutional hyponatremia. So the sodium in the blood is going to be relatively low due to the excess amount of water being brought back into the blood. Now, some of the causes, and I think I mentioned this when we were talking about cancer, that there are some tumors that will actually produce hormones, right? So brain tumors can do that. Again, head trauma can cause either too much or not enough ADH to be released. And malignancies like small cell carcinoma, they can release actually two hormones. They can release ACTH, and people with lung cancer can actually develop Cushing's disease or Cushing's syndrome, and they can release ADH. So you need to look for a primary cause. So there's a lot of drugs out there too that can cause that, so you have to be careful. And infections can do that. These bacteria can actually produce ADH. Now, what are the signs and symptoms? Most of the signs and symptoms associated with SIADH is related to the delusional hyponatremia. So it's neurologic. They're going to be confused, muscle weakness, everything's kind of suppressed, nervous system-wise. And then there's going to be low or no urine output. And we know why, right? Hang on, I got to sneeze. Maybe I don't. Hang on. Excuse me. And the reason there's no low or no urine output is because you have that massive amount of ADH. And then they're going to have low serum osmolarity. Why? Because if you remember, osmolarity is the ratio of stuff to water. So if you keep the stuff the same and you add more pure water, right, that's going to increase the osmolarity. Let's do this, right? 2,800 divided by 10. Keep the stuff the same, increase the water. So 2,800 divided by 20. The osmolarity goes down. Now, one of the big problems associated with that is pulmonary edema. Remember, you got the pulmonary capillaries and the alveoli. And because the blood volume is high, that can force fluid out of the pulmonary capillaries and into the alveoli. Now, how do you treat it? It's water restriction. And the other thing you have to worry about is trying to normalize that sodium chloride. And you got to determine a cause. So one of the things that they'll do if a person presents with symptoms of SIADH, they're going to, number one, do a chest x-ray because pneumonia can cause it and lung cancer can cause it. And they may do a CAT scan of the brain to rule out any damage to the brain, any small bleeds, recent head trauma, things like that. And then there's newer drugs called Vapins, or Vaptins, and they're ADH receptor blockers. Now, in the kidney, specifically the nephron, in order to insert these water channels into the collecting ducts, ADH has to bind to a specific receptor. So if you block that, even though you have a lot of ADH, if you block that receptor, then ADH will not be able to insert these water channels. And as a result, the water will get peed out instead of reabsorbed into the blood. But the one thing I will tell you is that if someone comes in with a complaint of, headache, things like that, and then you do a bunch of tests where you measure the urine osmolarity, the blood osmolarity, right? The blood osmolarity is going to be low. The urine osmolarity is going to be high. They're going to have a very concentrated urine because they're reabsorbing all that blood. You want to rule out cancer. That's the first thing you check. So that is diabetes insipidus and syndrome of inappropriate ADH, and I hope it helped.